Yeah, maybe we can now briefly discuss what this is all about. Yes, there is a question.
Mine is not a question, but an observation.
Yeah.
That this means all patients need to have phones.
Yes, and we mentioned it that all patients have to have phones, but we said that we may take advantage of those who have phones, but also some of those who may not have a phone. He may have either a relative they are staying together or another person who might have a phone, and then try to see whether he or she can use that to send a message. So we are trying to take advantage. We are not also, there may be two ways to say, should you look for a phone and give every patient? Probably, if you are trying to look at something sustainable within our system, it may be better to take advantage of what is available and try to see if those who don't have it, what can we do for them. But for the facilities, you need to provide at least a smartphone, because the patient's phone, the small one, can work for the SMS, but for the dot platform there, as you see, how can you monitor at the facility level? You need to have a smartphone, and we shall be providing a smartphone for all the facilities to be able to be used for that.
Yes, thank you very much. It looks to be a very good technology, but from experience regarding maintaining the phones online, especially in the villages, experience has shown that those people in the village, sometimes you call them, they are not available. They tend to call you, make their phone available when they need to call. So we need to take maybe care of that and see if the phones can always be online so that we can monitor it very well. Thank you.
That's a very important issue, and these are the issues that we are capturing, that even during the initial time when we initiate patients on treatment and we counsel them, these are important points that we need to bring out, that in order the patients may need to put on their phones either at a specific times or other times, because somebody say, I only charge it and I put on. My father happens that he has a time he puts on his phone, and that's the time I can call him. Beyond that time, you can't. So, but we need to put that into consideration. As the doctor said here, people put on their phones at a certain time, but in the initial, we need to assess all this and see how can we.
Thank you very much, Doctor, for this, which is apparently looks very nice technology. Mine is basing on what you initially communicated, that it has been tried elsewhere, and it seems the video is from that elsewhere where it has been tried. What was the margin of success between before it had been instituted in that place or in that country and after? I want to know the margin of difference. Then what is the 99 about? Why is it called 99?
Yeah, so the first one, where it has been tried in India and Myanmar, the data there show that patients' adherence went 90 and above. However, that data is not yet fully published. But the WHO and other, after reviewing that data, they looked at what was going on, and the national program in India decided to take it on and expand it. So there is convincing data that it worked well, though that data had not yet been put into publications. And so that's one. The second one was, what was the second question? Why it is 99 dots? I think I can't fully answer it, but I think 99 that you will take, 99% of the doses will be taken. And so that's one of the things. and we hope that that can happen. But WHO puts us that if you can take 90%, then we are even okay, but we are aiming to be even higher. So that, but one thing that, as you can see, these 99 dots, we are working with a company, Everwell. Everwell company is the company which developed 99 dots in India. So we are not the experts in 99 dots. That company team, we have been working with them, designing all this. They will be coming in here and training people here to use the technology more. So we shall be having a series of training with people from various sales facilities to get more to know what 99 dots and others. The 99 dots, we have been working with telephone companies, MTN, Airtel and others, to try to get toll-free numbers. And we are almost successful getting the toll-free numbers. Because one of the things that a patient is going to call, is it going to cost him? You have our 0800 250 250 if you want to call Stanbic Bank, call 150 150. It's toll-free even if you don't have airtime, you can call. We have also for electricity company. So the toll-free numbers, we are going to take advantage of. Our IT person who introduced us IT has been working also with the company to make sure that the companies locally here give us toll-free numbers so that people who call from their homes to those numbers, they are not charged. And that's one of the challenges that we do. Yeah. Any other questions?
Yeah, my question is about which in the end, at the end of the month, which results do we take? In one of the videos, the patient said she would always take and forget, but the dashboard will show that she has forgotten, that is not taken. And then we also have patient may have actually not taken it and just pills off. And also at the month, maybe they come and count those pills. So which one do we take eventually?
Yeah, and we are going to be elaborating more as I go through also what this 90 dots works. What do we take? She brings out an issue saying that I have taken and forgotten to send the message. And what do we do about that? So if you forget today to send the message, that's when someone calls you the next day to find out what happened. So the person who is managing the 99 dots platform, whether at the healthcare facility, can be able to overwrite that it was a missing, but actually I have verified that that dose was taken. So when someone misses a dose, then immediately you make a phone call to find out. And that's where we come in to work hand with community health workers or sub-county health workers attached to those facilities to say that our patient, even the phone is off, we can't reach him or her. What happened? Who knows where? Because there are these community health workers who know the units where people stay and say, I will go there. Then we pay transport for that person to go and visit the home. As you saw in the video, someone was visiting to find what happened to this patient and others. And so we want to also see that community health workers are involved to go and we support to go and visit those patients. And yeah.
Thank you, doctor. In the same line, my worry is supposing somebody consistently tells you that they are taking, but when actually they are not taking. Because why are we having 59% success? There are some barriers there. Not only what, but they are cultural. Others just don't want to take the pills. The same is happening in HIV clinics. That's why we are getting resistance. So in the event that some people, you phone them, they tell you have taken, but they are not taking. What assurance do we have as a program to ensure that those people now are reached and they are taking the drugs? Because we have been relying on somebody observing, but here we are now at the mercy of now the patient telling us she has taken or not taken.
Yeah, and this also the program manager may come in to say, the issue of relying on the observer. There are very many situations where we say there is a DOT observer, but probably there is none. The people have been doing more self-administered therapy. However, now someone has told you he has taken and is not taking. Definitely there are some patients who are difficult like that. And that's where now, sometimes when you have this platform, you will know some of the difficult patients. Maybe they need more focused counseling and wanting to know more deep. Why are they not taking this medicine? And this may also come out. As you see, there are patients who come back and you are put on drugs that you think are efficacious and are able to support these patients. However, you find that they are not improving. The first thing is that I gave them the drugs. Are they taking them? Can we verify? And maybe at that point we may say, is this blood drug in the blood? Can we take some test to see whether it's taking it? Or the quality of the drug is not what it is. So you start getting those, but definitely it will call on some focused understanding of these few patients who may not do that.
Okay, thank you. My question is about, I don't know whether I watched well, where each pill has a different toll-free code number. So we look at a scenario where patients, most TB patients, take more than 1 or 2. So does this imply that they are going to SMS like all the 3 tabs? And if he has only SMS'd 1, how are we going to do about that?
Okay. Thank you very much. That's a very pertinent question. And what's going to happen? The packages, the designs of the packages are being developed. We have worked with the national program. We already had a meeting with our Nakato, who is in charge of TB logistics, and looking at what should be the best design. What's going to happen with these drugs? The packaging of all the packaging of drugs is going to be done at the healthcare facility level. So we shall have those designs and the drugs will be repackaged at the healthcare level, working with the people at the health center to repackage those drugs into those envelopes of 99 dots. If our regimen for intensive case phase is 4 drugs or 3, so the package is designed in such a way that out of those 4 tablets, there is only 1 tablet where the toll-free number is. So the toll-free is not going to be, and as you could see on that package, there is where they show a phone, that's where the number is. So if the dose is for 3 tablets a day, then the phone will appear in the end of them. Then another 3 tablets. And so in that way, once you get that number, you just call that number. It will be only 1 number. And then the person will have been instructed that you take 3 tablets. One of them has got a number, and that's the number the person will be calling. But maybe as I go through more of this, you will get also more of this, but we shall also have more actual trainings with every unit to make sure this is very clear and what you are. Because the aim is that this should be clinic driven if it is to work. If it is to be driven elsewhere, then it is something for research and it's not going to affect any patient care. So,
I wanted to make a comment.
Yes, the program manager has to make a comment.
About the reliance on treatment observer and now on the patient. I think we are not going to do away with the treatment observers. The patient is going to have a treatment supporter, but the supporter doesn't have to be there every day to look at the patient to see whether they have taken drugs, but they will be visiting them more regularly to assess, to see whether the patient is actually taking drugs. Maybe one of the days in the design we shall look at the details you will reach there at the time the patient is taking the medication.
Yeah.
Yes. So we'll rely on the supporters as well. But also to note that before, we are not able to measure the patient's adherence in real time. This one helps us to measure the adherence, and we can tell that the outcomes we are seeing maybe are related to the patient adherence. Because you don't know whether the patient who is failing is taking their treatment, like for MDR-TB, sometimes, although we do DOT, sometimes you are not sure whether actually these patients are taking the... So these new technologies, the video, and this one can help us to measure adherence for the patient. Then the target of 90, which is the outcome, we want to see whether the adherence levels influence the outcome of patients.
Yeah.
But what I wanted to, since we have regional referral hospitals, I'm just praying that we are going to include the MDR-TB patients in this monitoring as well, so that we try to see whether this brings on board something that can help us modify the way we implement our DOT.
We discuss and see how to do that, but for this particular, we are trying to focus on the susceptible TB. We were seeing MDR as being well a bit, but we are going to think about it. Yeah, for sure. And as the program manager said there, we are getting information in real time. Studies have shown that poor adherence, actually, those who adhere poorly end up relapsing more. If you are supposed to take the drugs for 6 months, which would be maybe 180 days if you took them every day, you can still complete the treatment in 240 days, or 260, isn't it? You have completed, you miss today, you take another day like that. It has been shown that those patients are more likely to relapse, to fail, and even there are some studies which have already shown that those people are more likely to develop MDR if they take drugs over a long time than when it is supposed to be. So with that, the issue of trying to get real-time information about what's happening and coming in with remedies quickly helps improve that. So 99 dots based treatment. So there are 4 components of this whole structure of 99 dots. Patients will confirm daily medication dosing via toll-free phone calls. And so those are the phone calls when they take their tablets. Patients will receive daily dosing reminders via SMS. So every day at an agreed time, the system will automatically say, send an SMS reminder. There are some of these ones we get for either weddings or some function. You just see at a certain time, they have timed and it comes. So we shall also now using similar technology at a certain time, this an SMS program to remind you take your medicine. Then patients receive weekly check-in via automated SMS or phone calls to monitor for side effects. As you know, patients may get side effects after 1 week. Every week, there will be a telephone call to this patient, trying to find out if there are any side effects or anything. So in a way, trying to provide support to this patient by talking to the patient. Because the patient maybe is going to come back after 1 month or may even start to say, I should leave these drugs. You know, when someone takes rifampicin, the red becomes what? The urine, red. And even the sweat, if you sweat at night, you might find your bed sheets red. Patient may say, even I'm urinating blood, let me take away. So if there is that support, a weekly basis, and said, my urine turned red, if it not get, then it can be able to support and he continues this medication. Providers will be able to review the data via the dashboard. You will be able to review the data via the dashboard and can reduce frequency of refill visits or provide enhanced support to non-adherent patients. And this sort of differentiated care, depending on the needs of the patient, you can provide him different care and that sort of. So there are patients, we are going to evaluate one thing, that if a patient has been fully adherent throughout the first 2 months intensive phase, and you could ask this patient whether he would want to pick his medication every month or 2 months, you could give him a dose of 2 months. He's so adherent to the first intensive phase, to reduce, and you continue monitoring him with the 99 dots platform, and you see if there is anything, you can call back this patient or go and visit this patient. In a way, it may reduce the cost of patients having to come for medicine if they are adherent and they don't have any particular side effects. So these are the components of the 99 dots. So the objective that we want to do in this work is the dots beds intervention effective. And how we shall look at it, we shall determine whether 99 dots based intervention increases the proportion of adults with drug susceptible pulmonary TB who complete treatment in comparison to routine care. Routine care, as you know, we are collecting baseline data. Up to the end of December, we shall be collecting baseline data for each of the healthcare facilities. We are not going to compare Hoima Regional Referral Hospital with Bujiri, with any other, or Chiganda or Hessen. No. Each of these will be compared. We have a baseline. When we start, the things change. So we want to look at this baseline and also look at when we implemented that. So each health facility, you find that some health facilities are going to have more time before they initiate the intervention. As we say, it's going to be by chance who comes in first. So the first 3 will come in January, but the rest will be waiting. Another 3 will come in February and so on. So that data that will be there as far as adherence in the records, we shall be capturing it through photos and entering it and trying to see whether what's happening as far as outcomes are concerned. Can each component be implemented well and identify factors which influence the uptake? So you've seen there are 4 components. We shall be sending SMS. One thing that I realized with time, whenever you send an SMS, you think it reaches, isn't it? But does it always reach? No. Actually, we find that maybe only 60% or so of SMS reach. For you are sure, I sent the message to him. He's supposed to be coming tomorrow. Whenever I send an SMS and I expected you to respond and I don't, then I call. Because what we realize that with the SMS, it's not direct to the other phone's person. It goes to the company. The company now, MTN. MTN now, once it reaches there, it has to move now to. Once it reaches there, it may find the phone either off or something. It will try a few times to try to send the message to that phone. If it fails, it bounces back to the company. It may try again another time, but then it may remain now. For you are sure it reached. And so now we want to look at each of these components. What proportion of this SMS actually reach? Because we may rely on them. How many of those reminders reached when the patients called in and other things? So we want to look at each of those components, because by understanding each of those components, you can know why 99 dots did not work or what happened, so that you also understand the process. You may try to diagnose TB, but there is a process of diagnosis of TB. Patient who comes in should be screened, and if screened, should be sent to the lab. If sent to the lab, once done, should be sent back. It's a cascade. However, anything to break down in that cascade, you may say the diagnosis is not working. But if the clinicians are not referring the patients who have the symptoms to the lab, however much you say the lab has the tools to do the diagnosis, it cannot. So it may be that you need to talk to the clinicians, that the cartridges are there, the components are there, we need to do this. So the system must work. And so by looking at the different components, we shall be able to know, is it worth the additional cost? Determine the costs and cost effectiveness of the 99 dots. So we definitely added some resources. We put the platform, you have to send the community's work to the field pick, and it gets the. So if you compare the cost effectiveness versus when it is not there to routine care, is it worth? And that's an important point for decision makers to say, this is worth, I can spend an extra coin for this. And that's also part of that. How we are going to do it? It is going to be step-wage trial at 18 health centers in Uganda. All health centers start by providing routine care. I've talked about that. Each month, 3 health centers switch from the routine care to the 99 dots based intervention. The many health centers continue routine care until selected switch. Order that the health centers switch from the routine care to 99 dots based intervention will be random. We are here to decide who will come first. By the end of 6 months, all the 18, because we shall be taking on 3. So you are going to be the one to choose that I will come on board in the 6th month, not us. Compare treatment outcomes of eligible patients who initiate treatment during routine care and intervention periods across sites. All your centers will be switched to 99 dots by the end of the 9th month. So in terms of a picture demonstrating that, we have health center 1 to 3, 4 to 6, and so on. As you can see, we are, by December, we shall all be still doing routine care. Come January, 3 will come on board. During this period, we shall be introducing in the 3. So by the February, all those 3 will be on board. Then we start to go to the next 3 here and try to introduce them. So by the end of this month, all these, now these 6 will be on board, sort of like that. And at the end of 6 months, all will have been introduced. And then we shall continue also to monitor our patients through the dashboard to see who is not adherent. And so, in terms of data collection, we shall, for the objective 1, the staff of the healthcare facilities are going to be involved in collecting data, taking photos from the TB register, and also treatment cards whenever the patients come for the field. One thing, Madam Program Manager or Assistant Commissioner, we discussed earlier was the issue of treatment cards. I asked the members from these facilities, and they asked them whether they had treatment cards there. In some of the treatment facilities, the treatment cards are not there, and we've agreed that we shall be able to get the treatment card, work with the program manager, and be able to print treatment cards for these facilities for that period of time as we move on, maybe for a whole year, and as also this comes place, because they will also be important to tell us the adherence, and we shall be taking a photo for the treatment card whenever the patient comes for refill, and that one we shall be capturing and be able to look at that data. The study staff will be coming and extracting data from those photos and then entering it, so that we can be able to say, did our patient adhere as required or not. Objective 2 shall do some interviews of patients and staff, just to understand what is working, what's not working. Definitely, as you get involved, you can say, this is a problem. This makes it, why don't we do it this way and others? So through that, we shall be able to come up with the best way to implement this. And objective 3, they are trying to understand what's the cost of all doing this. Because we shall be able to know so many patients who are visited, this cost this, so many patients who are like this. unable to understand, because finally we want to go to the policy makers, program manager and the teams in the ministries to say, if you are to implement 99 dots, this is what it costs. If you are to implement, this is what it costs. The same thing which happened, Gene Expert is expensive, more expensive than microscopy, but when you compare how quickly you diagnose a case versus with the microscope, and even given with HIV it is more difficult to diagnose TB, then you can justify that, yeah, it's more costly, but we can afford it. A few years ago, when the HIV had just come, maybe it was still there, I remember people used to say a dose for a month was $1,000. Was what? $1,000. And then it was like a death sentence for us. So that drug can be managed in where? In the US. The people who have money, $1,000. But because there was need and other things came in, the drug is available for free. And so you can see these are some of the things that once we justify the cost and other things and show what, it can be key. So in terms of timeline, I would say we are looking that we are doing this baseline up to December, switch to 99 dots starting January, collect data from registers starting January and go on up to 2020 January, conduct patient and provider interviews, and also collect cost data. So that's what we intend to do as time goes on. We seek your cooperation. We shall be working with you. We shall be with you at those units. But as you see, we are also trying to see that this system moves itself at the healthcare facilities and appearing to have new people do it, because we may not change much in terms of staffing, but we want to see that how can we use this technology to improve the efficiency, the way we do things within what we have. And I would like to acknowledge a number of people. The TB Reach, as the program is the person who is funding, and this is sort of like a movement, TB Reach, to help improve TB control over the world by trying to come up with innovations that can help us either increase case detection. Now there is the element which is new, which is improving treatment outcomes. The number of people or organizations that we are working with to help move on this. So